Hello, everybody. Thank you for joining. We're just going to give people a few minutes to log on, and maybe we'll get started in about 2 minutes or so. Okay. For those of you just joining, thank you so much for joining. We're just giving people another minute or so to join, and then we'll get started. All right, I think we're going to get started. I know people will join when they join, but I think given the hour, it's now 12:02. I'd like to officially launch our seminar and welcome you all to the University of Toronto Network for Healthy Populations, BBDC Joint Clinical and Population Research in Progress rounds today. And it is my great pleasure to invite Dr. Calvin Key, who's going to be presenting today. But before we start, I just would like to begin with a land acknowledgement. So we'd like to acknowledge that the land on which the region of Peel operates is part of the treaty lands and the territory of the Mississaugas of the Credit. And for thousands of years, Indigenous peoples inhabited and cared for this land. In particular, we acknowledge the territory of the Anishinaabe, the Huron-Wendat, the Haudenosaunee, and the Ojibwe Chippewa peoples, as well as the land that is home to the Métis, and most recently the territories of the Mississauga of the Credit First Nation, who are direct descendants of the Mississaugas of the Credit. And we're very grateful to have this opportunity to work on this land, and by doing so, give respect to its first inhabitants. So welcome everyone, and thank you for attending today's research in progress rounds entitled Adapting an Innovative Model of Care for Young Adults with Type 2 Diabetes, which is presented by our very own Dr. Calvin Key. And before I introduce you to Calvin, I just want to review some housekeeping items. So we appreciate our audience muting themselves during the presentation. There will be an opportunity for questions at the end of today's session, and we will be inviting questions both in the chat box or if you'd like to use the raise hand function. If you have questions during the event, please put them in the chat box. We'll do our best to answer as many as we can at the end of the session. And lastly, please note that today's session is being recorded, and we will make the recording available on the network's website. So now I'd like to introduce our speaker for today. Dr. Calvin Key is an assistant professor in the Department of Medicine and the Institute for Health Policy Management and Evaluation at the University of Toronto, as well as a clinician scientist at the Toronto General Hospital, an adjunct scientist at ICES, as well as a staff endocrinologist at Toronto General Hospital at the University Health Network. His research is focused on epidemiologic and applied research, an epidemiologic applied research lab called the YoungOnset Diabetes, apologies. And you can find his website at earlydiabetes.ca. And he also leads the Health Services and Quality of Care Working Group of the Novo Nordisk Network for Healthy Populations. And he received his Doctor of Medicine from the University of Toronto. He then went on to complete his residency training in internal medicine at the University of British Columbia, and then came back to Toronto for his endocrinology and metabolism training. He then went on to complete a PhD in clinical epidemiology and global health as a global scholar at the Institute for Health Policy and Management and Evaluation at University of Toronto. His research interests include the management and outcomes of type 2 diabetes with a focus on young onset type 2 diabetes, especially in the Chinese and South Asian populations. He did conduct research internationally across Canada, China, India, and Guyana. His research publications have appeared in high-impact peer-reviewed journals already, such as JAMA, Annals of Internal Medicine, Diabetes Care, The Lancet Global Health, PLOS Medicine, and Nature Reviews Endocrinology. More about Calvin. He actually previously served as an honorary visiting scholar at the Chinese University of Hong Kong, and he's received multiple awards already, including the Canadian Society of Endocrinology and Metabolism Dr. Fernand Labrie Fellowship Research Award, the Queen Elizabeth Advanced Scholar Award, and the South Asian Network Supporting Awareness and Research Burgundy Young Investigator Award. He has a lot of other commitments, including associate editor on primary care diabetes, section editor of current diabetes reports, national consultant editor on Canadian Journal of Diabetes, and many other jobs. He is also a second-generation Chinese Canadian with roots in Hong Kong, and he engages closely with ethnically diverse communities in his research and clinical work. And with that, it is my great pleasure to pass it on to Dr. Key, who will take it from here to speak on his presentation today. Go ahead, Dr. Key.
Thank you so much for the kind introduction. I'm happy to share with you today some of our work on adapting an innovative model of care, specifically for young adults with type 2 diabetes at this research in progress rounds. These are my disclosures. So this talk is going to be in two parts. The first part is going to focus on team-based diabetes care and specifically comparing models of care, what we have in Ontario compared to other jurisdictions such as Hong Kong, and what we can learn from that comparison. And then the second part is going to be talking about adapting a specific model of care and specifically the role of cardiovascular risk communication in the population of young adults with type 2. And so I'll focus now on the models of care. So this audience needs no reminder of the standards of diabetes care. And, just for the trainees, as an archetypal sort of chronic condition, there are certain targets and aspects of care involving managing blood sugar, blood pressure, cholesterol, drugs, and changes in healthy behaviors in order to be able to manage diabetes optimally and prevent complications such as cardiovascular disease, renal disease, and premature death. And in order to achieve all these things, it's very difficult. And the standard of care in Canada involves the involvement of a team, so team-based diabetes care. And this is a health systems level. It's an organizational intervention that incorporates team members, most commonly nurse educators, dietitian educators, but can also include other roles, including pharmacists, psychologists, social workers, and other people who work together along with physicians to help patients manage their diabetes in the most optimal way possible. And so there's good evidence that team-based care improves diabetes self-management alongside the ideals of empowering patients, educating them, and helping to promote behavioral change and taking medications. There's good evidence that this type of approach improves risk factor management and reduces hospitalizations. But there's a lot of gaps in access to this type of care and implementation. And there's not a lot of research on, how we specifically implement this. It just seems like they've sort of grown out organically. And comparing different jurisdictions and how they've, implemented this type of approach can really highlight innovative solutions for Ontario and how we can improve our own system locally. And so, one of the motivations for doing a comparative approach is that, there's certain innovations that arise in different parts of the world. And one of the really exciting innovations, I think, over the past 20, 30 years is this sort of program that was led by Juliana Chan at the Chinese University of Hong Kong, which has been called the JADE program and now has been renamed to the RAMP-DM program. And there's been a lot written about this program. And, I think we can take this opportunity today to sort of delve in a little bit further about what was done and what's so, exciting about this and how it compares to Ontario. And so my family is from Hong Kong. My parents immigrated here in the 1970s, along with other immigrants at that time, in search of better opportunities. It's located in the southern part of China. It has a population of 7.5 million people in a very, very geographically small area that's highly, highly urbanized, the fourth most densely populated place in the whole world. Really hustling and bustling city. You can really feel the energy and the pulse of the city. As soon as you get off the airport, it's a very humid place, and the energy is just unparalleled to any other place I've been to, really. And so, a place like this is very different from Ontario in many ways. And so, are these systems really comparable? Well, they are in some ways, but there are also other differences. So, just briefly talking about a little bit of background, Hong Kong has a health system that is similar to the British NHS. The regulation, the financing, delivery are all governed by the state, whereas in Ontario it's privately delivered, but publicly financed and publicly regulated. And the organization that governs all public hospitals, clinics, and physicians is called the Hong Kong Hospital Authority, or the HA. The financing is a little bit different as well. In Ontario, all of it comes from tax. 2/3 comes from taxes, and the other comes from federal transfers. But in Hong Kong, the spending on healthcare systems is a combination of taxes and a very small percentage of user fees. So less than 5% of the financing comes from these fees that patients pay. It's about $8.50 per outpatient visit. So it's not a huge amount, but it also includes everything, including their medications, their laboratory tests, basic procedures, and people who are in low income or vulnerable groups, they get their fees waived. So there's a social safety net. And then there's also this parallel private system that people with private insurance or people who pay out of pocket can go to. So in terms of the service delivery, the public system has a really huge role in Hong Kong. There are hospitals, there are general outpatient clinics, which provide primary care. There are also specialist outpatient clinics that also provide care for conditions such as diabetes. And it accounts for about 90 to 95% of inpatient services and about 30% of outpatient services, because a lot of outpatient care takes place in the minimally regulated private sector, where primary care and specialist physicians also work. This is different from Ontario, where these services are concentrated in the public sector, including primary care in a variety of different settings, including community health centers. The workforce is also a little bit different. So in Hong Kong, about 45% of physicians are employed in the hospital authority, and actually more than half are actually working in private settings. The public physicians are salaried employees, and the private physicians, they generally charge fee for service. A unique aspect of Hong Kong is that they have a territory-wide electronic medical record. So because everything is governed through the HA, any hospital you go to, you have your entire medical record in that chart. And so it's very comprehensive in that sense. Private doctors do not use that chart, but they can actually register for access to that EMR for more complete information. In Ontario, our system, as most of you probably know, is more fragmented, different electronic health records across different hospitals and different clinics, but there are some efforts to mitigate that fragmentation using centralized repositories. Access to essential medications, very important for diabetes. In Hong Kong, patients who attend public clinics can get their medications through their nominal fee of $8.50. They can get all their medications. And so because of that, because diabetes, most of our patients with diabetes do end up being treated with some type of medication. And so more than 90% of people with diabetes do attend these clinics, and medication is a really strong motivating factor. In Ontario, our coverage for medications is more fragmented, but that may change in the future with recent federal announcements. And so, there are some differences across Ontario and Hong Kong, and some of these differences stem from structural and systemic factors. And the other difference is in the way that diabetes care really evolved. And so in Hong Kong, it really was a local process that really was scaled up over time. So in 1995, the Chinese University of Hong Kong, or CUHK, and Prince of Wales Hospital, under the leadership of Professor Chen, pioneered a local research-driven quality improvement program. And so they called that the Hong Kong Diabetes Register. It included tools for risk stratification and enhanced decision-making. I'll show you an example of that later on. So this has been in the works for quite a long time. It's very well established. And the idea is not new. It's implemented some time ago. And so this is a map of Hong Kong. You can see down here is Hong Kong Island, very densely populated. And then up here is the areas known as the new territories. The HA is split up into different clusters, and there are different hospitals in each cluster. The Prince of Wales Hospital is located in this northeastern region called the New Territories East Cluster, and this is where this entire program began. And so this is a picture of the Prince of Wales Hospital. It's a place where I went to work during my research training every day for a year, learning about this program and working with their data and learning about their EMR. And so in the year 2000, they actually incorporated this protocol that was originally on paper, and they incorporated into their EMR in the HA. And they also created a new nursing specialization. So whereas in Ontario we have certified diabetes educators, this didn't exist in Hong Kong, and so they created a new specialization for nurses who would provide special diabetes services. In 2007, they actually digitized the Hong Kong Diabetes Register protocol, which provided tools for risk stratification, and that was known as the Joint Asia Diabetes Evaluation, or JADE. And I'll show you what that digitized version looks like. So this is from a publication describing the system. It was published in 2010. And so it's a web portal, and there are many different aspects of the assessment. So there's information that's collected on things like personal and family history, complications, what type of education they've had, what type of follow-up, self-care, other relevant medical conditions, physical exam, eye and foot examination. So all of these things are actually delegated to these nurse case managers who go in to the patient's chart and do this assessment. They're very specialized and highly trained for this purpose. And so this information all gets fed into the JADE system. And what's really unique is that it outputs the information to the patient. So it's not only information storage, but it actually gets outputted, and the patient gets a personalized report showing them about what their blood sugar levels are, what the blood pressure is, what the cholesterol is, and what the trend is over time, and what the targets are in order to reach the optimal management targets that we have in our standards of care. And it contains personalized recommendations so that the patient can understand, as well as their primary care provider and their other physicians. They also get a copy of this report, and they understand what they need to focus on based on these very powerful recommendations. The other really unique aspect of this is that the information that's collected in that assessment all goes into a specific algorithm that takes these variables, so their body mass index, gender, the other variables that are available in the chart, lab data, demographic data, and it all goes into calculating the 5-year probability of experiencing a complication such as cardiovascular disease or end-stage renal disease or heart failure. And so patients can understand, am I a person who's at very high risk, or am I currently at a very low risk? And they can make decisions and be more empowered with this information about understanding why people are concerned about managing diabetes, and what sort of all the focus is on preventing these types of complications. And so this is what it actually looks like in practice. It's also from one of the assessment sites that's available in Hong Kong. So this is all sort of nurse-driven, and they do blood tests on site. They check the urine on site. They get their eye exams on site, their pulses, their foot exam. Everything is done so a patient can kind of have a one-stop shop and know about all the aspects that are important for diabetes care and complication prevention, and get all of this fed back to them in the form of a report. So this is really an innovative approach to diabetes that's quite different than what we see in other parts of the world, including Ontario. So this really got the attention of a lot of policymakers in Hong Kong, and they were seeing the potential opportunities in scaling up this system. And so they actually implemented this system in 2009 and they changed the name to RAMP-DM when it was officially adopted by the HA. And they started off in these two clusters of hospitals and clinics in 2009. And very quickly, seeing the success of this program, they scaled up across all of Hong Kong, all of the public clinics and hospitals in 2011. So it has been in place since that time for the past 13 years and continues to be very successful. And this is another way of looking at how it works. So we analyzed the processes of how this all works. So somebody gets their diabetes diagnosed. A lot of these patients are followed in primary care settings, such as the general outpatient clinics in the hospital authority. And so everyone with diabetes in these clinics will get referred for this type of assessment. It's automatic. Nobody has to put in a request for this to happen. It's automatic. This is the RAMP DM, and they will undergo these assessments. And based on the assessment, there will be a risk stratification. Is this person at high risk, moderate risk, or low risk? And based on that, then their follow-up is tailored. So people with high risk will be seen more frequently and they will receive more intensive support, whereas people with moderate or low risk, it will be a bit less. And this is sort of another aspect of this that's really attractive to policymakers. It's the sort of resource management. We're not going to, we have to allocate the resources wisely. And so risk stratification seems to be a logical way of doing that. But there are also patients who don't attend these general outpatient clinics. Let's say they see a private physician who's not part of the HA. So these patients, they don't generally receive team-based care unless that physician specifically has a team, which would be uncommon in the private setting. But there's actually now a public-private partnership program where patients from the private sector can be referred into this PPP and get the same type of risk stratification, and they receive annual follow-up there. So there is that option. In Ontario, our diabetes education programs developed a lot differently. So around 1992, there was this understanding that diabetes reform was really, really important thing. And so there were 50 hospital-based diabetes educations that were developed. And you can see the timeline here. This was developed and increased over time. And there were more programs that were added in hospitals, but more also in the community and family health teams, community health centers. And the administration has changed over time. So it used to be under the LHINs, and now it's under the Ontario Health Teams. And there's various frameworks that have come into place. But I would say that the overall structure and the way that things are run, hasn't changed a whole lot over the past few decades, even though the standards have been updated and those are followed. But the overall approach and the structure is still very much similar in spirit to when these policies were first implemented. And so in Ontario, people who are diagnosed with diabetes, they might be seen by a primary care provider who works in a team-based setting. And some of these team-based settings, such as family health teams, some of them do have an integrated diabetes education program. And so these patients, they would get usually referred into this program. And the follow-up is individualized to that patient's individual needs. There isn't a standardized risk assessment, but there is some sort of clinical assessment that takes place, and the patient does have their follow-up individualized. Some team-based primary care settings do not have a built-in integrated diabetes education programs, but there is an option to refer patients to an external site for this type of education. And again, that would be individualized education, individualized follow-up. There are other patients who might go to walk-in clinics or see family physicians who don't work in team-based settings, and so they wouldn't receive team-based diabetes care because there's no team. But some of these patients do end up getting referred to an external site, and so there's an option to go to an external diabetes education program. And so these are how the processes look in Ontario compared to Hong Kong. There's some parallels, but it's also really quite different. There have been no systematic comparisons of what the outcomes are in Ontario compared to Hong Kong, because the studies are so different, and the populations are different. It's hard to adjust or control for all of the relevant aspects in this type of research. But there are outcome studies that were done in each jurisdiction individually. And so in Ontario, one of the most important studies was done by our own Deju Shaw, who was a chair in this network. And it showed that attending diabetes education program, this was back in 2006, was associated with increase in the quality of care, which was defined as the presence of retinal screening examinations, having hemoglobin A1C tests, having cholesterol tests. And you can see that there was a significant 2 to 8% increase in these types of measures as a result or associated with attending diabetes education programs. But when they actually looked at the outcomes in terms of complications, so cardiovascular disease, amputation, retinopathy, mortality, there actually was not a significant association in terms of attendance at these programs and outcomes. And so this was adjusted for the baseline characteristics that were measured. Obviously it's not a randomized controlled trial, so there's confounding in place as to who gets referred to these programs, who actually attends. But this is what the data showed, based on the observational findings. This is the best information that we have. In Hong Kong, there have been systematic evaluations similarly of the RAMP DM, and now it's been operational for a long time now. They did a 5-year evaluation. Now there's data just published in Diabetes Care in 2022 of a 10-year evaluation. And they did show that these metabolic risk factors among people who attended usual care plus RAMP DM, all these measures of things that we care about, blood sugar, blood pressure, cholesterol, body mass index, renal function, they did look to be better among people who attended this program compared to people who only attended usual care. So these were people who, despite the automatic referral, they didn't end up attending. So there may be systematic differences in those two populations, but this is what the observational data show. And this is over 10 years. They also looked at the complication rates. So using a propensity score matching method, they actually found that there was an association with a 32 to 55% reduction in microvascular, macrovascular, and mortality complications among people who attended usual care plus RAMP DM compared to those who attended usual care only. And so, these data are not perfect. These are observational findings, but there does look to be a suggestion that there may be a difference in sort of outcomes that we're seeing in Hong Kong compared to Ontario. And if we accept that there's that there are differences in these outcomes, it's useful to look further and to understand what are the specific differences in these programs that might have affected the outcomes that we're seeing. Well, one of the important differences is the accessibility in the first contact, initiation of the referral. So in Ontario, physician referral is actually mostly required for most diabetes education programs. Some of them do allow for self-referral. Actually, there's supposed to be self-referral available, but it's often either underutilized or not permitted. And less than 50% of the family physicians in some studies actually routinely refer their patients to these programs. And only 1 in 5 patients are attending within 6 months of diagnosis. But this is a standard of care. Everybody should get this, according to our standards. In Hong Kong, everybody is automatically referred. So you bypass this referral process and a lot more people get connected. Continuity. So barriers to attendance are, similar, I would say, between both places. People forget about their appointments. They don't think it's useful. The mental health issues. But in Ontario, I would say people generally follow up with the same primary care provider if they have one. In Hong Kong, there are challenges to staffing and the healthcare workforce and the HA. They serve 90% of people with diabetes. It's only 45% of physicians in Hong Kong. And so a lot of patients who are coming to these general outpatient clinics, they see something different every time. And so there's a little bit of discontinuity there. And they're often going to the private sector if they have acute issues because they just can't, they're not able to be accommodated. And so sometimes the continuity of care may be suboptimal. But they're doing their best within the confines of a publicly funded system. The comprehensiveness is also very different. And so in Ontario, there's information that's provided about foot care and eye services, but those types of providers are not routinely available on site. Whereas in Hong Kong, there's a nurse case manager, and they will refer you directly to an in-house person who checks their feet and the eye services. So that's very different. Medications are also very different. So their medications are provided on site. So you go to your appointment and then you go to the pharmacy department, you pick up your medications. You don't take your prescription and go somewhere else to pick up your medications. And the costs are all covered if you go to the HA clinic. And so that's a strong motivator. Whereas in the private sector, you do pick up the medications from the doctor that you see generally. And so it depends on what they have stock, but there's a lot of out-of-pocket costs. And another key difference is also the electronic health record. There's a territory-wide electronic health record, so it allows for these sort of comprehensive studies to be done, whereas in Ontario, we're relying on administrative health data, which often doesn't track certain parameters such as diabetes education program attendance. There's also differences in terms of the patient-centered focus. So in Ontario, we use an open-ended, flexible patient-centered approach, and shared decision-making is a very sort of important value that we focus on. And the nurses and dietitians who are often employed in these settings, they're often certified diabetes educators, although patients in some evaluations perceive that the quality of education, they perceive it as variable, depending on where they went. In Hong Kong, it's a very different approach. It's more systematic. It's very structured. The questions they ask, and the risk stratification, and even the follow-up is all very much standardized, and so that's very different. And there are dedicated nurses who serve as case managers for that patient, but again, the availability is limited by staff workload. So, are these regions really comparable? There are many similarities that allow for comparative analysis. High-income regions, universal healthcare systems, well-established primary care, similar degree of the diabetes epidemic in both places. But we do have to limit our interpretations by understanding the differences that exist, and the structural differences in the care system, geographic differences, and it's easier to provide care to people who are all living, closely together in the same place in terms of, situating clinics, and, we don't have issues of, people being physically far away from clinics in Hong Kong as we do in some parts of Ontario. There are demographic, cultural differences. So, I think we can learn something, but, we have to be careful about the interpretation as well. And so, I think in our comparison of this that we published just last year, there are many other aspects that I don't have time to go into today. But we thought that that this type of care is most successful and functional when the team-based services are integrated, and arguably an automatic referral upon diagnosis works very well for patients in a strong primary care system, and specialist care being available when needed. That's also a very useful thing. And in Hong Kong, at least, structured assessment and risk stratification, seem to be the basis of a very well-established approach over there for providing diabetes care in a team-based setting. But we also have to note the differences, and we may need some flexibility in the type of care delivery to meet the unique needs of some individuals with diabetes, and to be able to adapt these systems and be able to really have them also be effective when we implement them in other places. And so I'm going to shift gears now and talk about how we can adapt some aspects of this type of care, and what we might do in Ontario, and what the evidence is for these specific things. And so there's a lot of talk about adapting structured assessment and risk stratification. This is the Lancet Commission on Diabetes. It was published now 4 years ago, but it generated a big splash when it was published. And I think that the themes of this commission, which was led by Professor Chen, really do resonate and inform a lot of what we do at the network, especially with regards to diabetes prevention and management. And so there's a recognition that diabetes is complex, and we need to provide supports to meet the needs of these patients. and that there may be an important role for structured assessment to personalize care to prevent complications. But at the same time, we need a multi-layered and societal strategy to be able to prevent these cases of diabetes from occurring in the first place. And there are very diverse causes of these conditions that we're seeing, and that the delivery of team-based care is very important, and that we need better systems, electronic medical records, and diabetes registries or registers for better surveillance, prevention, and treatment. And so this is kind of schematic that was shown in this commission, and it very much mirrors the approach that's been used in Hong Kong, sort of registering patients, doing the systematic assessment, stratifying patients, focusing on risk factors, and then just this cycle that's really circled around self-management and treating to multiple targets that are evidence-based and providing the ongoing psychosocial support that's needed. And then on the other side, actually doing the population-based studies and linking that to data on hospitalization, on mortality, that can really be very powerful to inform decision-making. And this is sort of one of the consensuses in how we should approach diabetes care in the ideal setting. And so this is another figure that sort of illustrates those concepts in a different way, talking about the importance of structured assessment and registries and providing that ongoing support. But I think we also need to consider, how we adapt these to the local context. And so, in our report, we tempered our interpretation by recognizing the differences that exist between Ontario and Hong Kong. Obviously, demographically is very different. In East Asia, there are a lot of health economic studies that show that people generally hold, and obviously, it's not to generalize or, paint with a broad brush, but in these health economic evaluations, there tends to be a more risk-averse long-term view of health that does respond very well to risk predictions. And so that might be one aspect of the population that supported the success of an approach like this. And people who hold Confucian values, which is common in East Asian countries, respect physicians specifically for their ability to offer solutions. So they're coming into an appointment expecting that they would be told something. Whereas in Canada, our situation is more diverse. It's we value shared decision making, patient autonomy, empowerment, and so there may need to be some flexibility and adaptation to the local context. There may also need to be some flexibility and special considerations for special populations. So one of the areas that that my research focuses on is young adults with type 2 diabetes. And one of the important reasons why we need to focus on this group is that younger diagnosis of diabetes is associated with an increased risk of complications. So you can see in these survival curves that people with young onset diabetes are the most likely to experience complications over their lifetime compared to people who develop diabetes later, which we define as after the age of 40, and also compared to people without diabetes. And so this increased complication risk is very important. And so the management of diabetes, is really very, very important in this specific age group. And so we decided to take this a bit further and actually look at the evidence and develop new evidence about what the role of communicating risk predictions could be among young adults with type 2 diabetes, defined as people diagnosed before the age of 40 within the past 10 years. And so in terms of risk stratification, there's so many approaches to risk stratification. These are some approaches to cardiovascular risk stratification, Framingham risk score, the score, and there are many of these that, they take people's characteristics and they give you, a number that represents your risk of having some sort of complication over the defined period of time. And so, why should we actually present this when we're talking about self-management? Well, there's some information that suggests, and this is mostly smaller studies that was done in people without diabetes, but these studies suggest that if you show people that they have a high risk of something, the higher that number is, the more the impact on their behavior. And that's actually studies that were done in cardiovascular disease prevention and looking at dyslipidemia. They actually found that there was a greater impact if the number was higher. Comparisons to peers may be useful. So if you say, this is your risk and this is somebody's risk who doesn't have diabetes, that might increase the perception of that risk, and it might lead to some emotional responses among those patients. If you show people numbers paired with graphics, that might increase the accuracy of that perception. But we still don't know what the best format is. How should we best communicate that risk? It's done in a certain way in Hong Kong, and that grew out of the long history of the RAMP-DM program and the JADE system that's been there. But there have been very few studies, almost no studies, I would say, that have looked at what is the best format to present this risk, and specifically what's the best way in young adults with type 2 diabetes. And we also don't know what the influence of this risk perception is on the self-management of type 2 diabetes. So we've done some preliminary work in this area. And so I'm indebted to our medical student, Mosana Iroha, who worked with us through the SPARK program at Sunnybrook, and also my very skilled research associate, Joyez, who worked very hard to collect this data that I'm going to show you here, and I want to acknowledge their contributions. So, the focus is how should we present cardiovascular risk predictions to young adults to enhance type 2 diabetes self-management. And so we needed a framework for this study. And so in the health behavior literature, I'm not a psychologist, and so but a lot of the work that we're doing really involves health behaviors. And so in this specific framework, which was proposed by Michi et al., was published in Implementation Science, somebody's health behaviors is related to their capability of performing that health behavior. Let's say you want somebody to take insulin. Are they physically capable of holding an insulin pen and injecting that insulin? That's an example of capability. Opportunity. If you want somebody to do physical activity, do they live in a neighborhood that is walkable? Do they have the opportunity to do that behavior? That's an example of opportunity. And then motivation. Is somebody motivated to do something that you're telling them to do? And so those are the three key things that influence, according to this framework, somebody's health behavior. Then what's built into that, the COM-B system, is the behavior change wheel framework. And so there's a source of behavior, so that system that I just defined in the green wheel. And then there are these interventions that we can do. So, this type of intervention, we could call it educational intervention. We're providing information on somebody's cardiovascular risk. That's a type of education. But there are other ways that you can modify somebody's behavior. You can give them money for doing something. That's incentivization. You could coerce them to do something. You could train them. You could model that behavior. So all of these different interventions are part of this behavior change wheel framework, and they affect somebody's capability, opportunity, motivations differently. And then there are also policies. There are broader policies. You can change somebody's environment. You could, legislation, guidelines, different things that we can do, often in a public health setting, with a goal of modifying behaviors. And so, I fully acknowledge that, a lot of people, do know what's good for their diabetes, but they're limited by socioeconomic factors or structural factors or things that are beyond their control. Ability to afford healthy food, or their physical environments, and those factors are all very important and things that we focus on very much in this network. But there's also the behaviors and the motivations to do those behaviors, which is another aspect that self-management education tends to focus on. And in this particular intervention, the focus is on how this type of education can affect their health behaviors. And so in this framework, there's actually a link between these types of educational preventions and somebody's capability, their psychological capability to enact that behavior. So, their ability to even know that that's something that they need to do, take their medications, physical activity, diet, etc. And then there's also the motivation. The motivation is characterized in different ways. There's reflective motivation. So this is like somebody thinking about their cardiovascular risk and really saying, this is a very high risk. I need to be worried about this. I'm going to focus more on doing physical activity. And so that could be through education, but it can also be through how they feel emotionally. They see a high risk and they think, wow, I'm very worried about this. And so they might be more motivated to do it. And so this is reflective motivation. Or there's also automatic motivation, which is, somebody feels very worried about something, but they're not consciously reflecting on it, but they actually are motivated to do that behavior. And so there are many other aspects of this framework that I'm not going to focus on because it's not part of our intervention, because I want to show you some of the data that we have. And so this is our methodology. It's a mixed method study. We developed 6 different types of risk predictions, and we rated their accessibility, credibility, and emotional responses. And we also explored the role of this communication in enhancing self-management behaviors through qualitative interviews. There are principles of how we should present risk information, but they're not very prescriptive in how you should do it. There are certain things with the design, but there's still many ways you could present the risk and follow these standards. And we use this sort of mixed methods, concurrent triangulation approach to, I think, really nicely provide some of the quantitative and qualitative data to inform this type of work. And so these are the baseline characteristics. It's a very diverse population, socioeconomically and ethnically. Those are the characteristics there. I want to emphasize this is very preliminary. This is a research in progress presentation, and so this is not finalized yet. And so, so these are only preliminary results, and they may change as we continue to recruit people across sites. And these are some of the results that we're seeing, though. So one way of presenting the risk is, show somebody the risk and then put it on a scale and label that. So this is your risk of a heart attack or stroke in 5 years. This is your risk. This is somebody without type 2 diabetes. And so we asked people, what do you think about this? And so people thought this was confusing. They thought, they're in low risk category. This low risk we would expect because it's a 5-year risk and they're young. And so they're not at a, huge 5-year risk of having a condition. So they actually, felt very reassured and they thought, okay, it's okay. And, I might do a bit of exercise, but, it's not really a big problem that we have here. This is 5-year risk displayed in terms of a bar graph. And so, people thought this was very straightforward and clear, but, there's a perception that's not really an urgent problem. It doesn't seem to be that big of a deal. I don't really need to, worry about this too much. This is the information that's being shown. There's also icon arrays. So in some types of presentations, this seems to be a very useful thing. But then again, displaying the information in terms of a 5-year risk, it's clear, but it didn't really evoke any strong emotions, and people didn't really think that was a very significant thing. Then we tried to do this and show people a lifetime risk. There's more and more information that's showing a lifetime risk is something that we should care about, especially in young adults with conditions like type 2 diabetes, because that lifetime risk is so huge. And that's, in the end, what we're trying to prevent. It's those complications that occur, not within the next 2 or 3 years, but within that person's lifetime. So lifetime risk of cardiovascular events is actually very high compared to people without diabetes. And so people thought this was very clear. And they expressed a range of emotions. So this is a score that's out of 10. So more positive emotions for this, that they experienced, there was a range of fear, anxiety, sense of urgency to make changes. And, some people, felt a little bit anxious when they saw this. We also showed them lifetime risk in terms of an icon array, and they did see that this was accessible and clear, and that there was a strong level of perceived urgency and credibility of these estimates, and they were motivated to actually acknowledge and potentially act on the risks. And it really put the issue into focus. There are some people who think that cardiovascular age is something that we should present, and this is the idea that somebody's cardiovascular risk is a reflection of how fast their heart is aging. And so let's say they're currently 30 years old, but their heart might be 47 years old, and this is puts them at higher risk of complications. But our participants found this a bit confusing, and they didn't really know what it meant. One person understood what it meant, but and that got led them to be more motivated, but it wasn't universally seen that way in our population. So, lifetime risk may be really useful if we're talking about structured assessment and presenting these estimates, especially among young adults. And they do elicit a mix of different emotions, but they do effectively communicate the magnitude of that risk. And there does seem to be an effect on motivating people's self-management. Obviously, these are not their risks that we measured in this study. They were hypothetical risks, and they said that they would be motivated, but whether or not that would actually lead to improvements in risk factor management, that has yet to be seen. But at least there's some basis for including these types of estimates in an intervention where we would enhance self-management diabetes education with these types of estimates and with personalized recommendations. And so I'm going to wrap up here so that we have some time for questions, and emphasize that multi-jurisdictional comparisons are, I think, really useful in generating these types of insights that can improve diabetes team-based care, and that we need implementation science and behavioral change frameworks to guide the adaptation of these approaches. And that, I think that lifetime risks are very important for motivating self-management potentially, especially in young adults with type 2 diabetes. I want to acknowledge all the people on the research team and Professor Julianne Chan for coming up with all these fantastic ideas, and all of our community partners and co-investigators on our team. Thanks a lot for your attention.
Thank you so much, Calvin, for a very informative and interesting presentation. A lot of information, and congratulations on all your hard work so far. I'm going to start by seeing if anybody in the audience has any questions. Please feel free to raise your hand or just come off mute. Guess while people are thinking, maybe I can ask you. So Calvin, I think that's very interesting about the how best to your work on kind of getting an understanding of how best to present research information, particularly to young adults. My question though is there evidence, and can this evidence be translated into sort of another motivator for behavior around the benefits of early intervention on long-term outcomes in young adults? I mean, so for example, it's one thing to say, yes, my lifetime, because we see this, for example, I do a lot of work in post risk of diabetes after gestational diabetes. And one of the kind of misunderstandings that young women have when they are told they have gestational diabetes, this increases their risk of type 2 diabetes later, is they think, oh, that's going to happen to me way on down the road. I don't have to think about it. But we actually are able to show that not only does that risk increase early in the first 5 to 10 years after delivery, but that interventions can, like, doing healthy diet, physical activity, and all of that actually can lower your risk of getting diabetes. So having that second piece.
Yeah, no, I think you bring up a really, really important point, and I think that was also brought up in some of the interviews. How would this risk look if my blood pressure was better, if my blood sugar was lower, and showing the sort of before and after of how that would look. And so, I would say that wasn't specifically, to my knowledge, built into the JADE system, and it would seem to be a very important thing. Because as you mentioned, the early benefits of early intervention are very clear, and I think that could be built in, but we haven't specifically looked at that piece yet.
Or even just asking, I don't know if you're continuing to do interviews, but you could even just ask to what extent the different ways of providing that kind of information would help. How compelling would it be to them to be told that there are things that can be done now that can reduce your risk of stroke later, as an example. And I guess along those lines, you spent some time talking about different models of care. Do you see any kind of tailored approaches within the way in which diabetes care is delivered that we can consider for people who have young onset diabetes for various reasons?
Yeah, no, I think that this type of structured approach and the presentation of the risk information is particularly useful for young onset type 2. I think with young adults, people are more and more comfortable with data nowadays, and these young adults, a lot of them are very, savvy, and they want that type of information, and they'll act on it. And I think that a lot of this sort of gets lost when we group all adults together and manage them in the same way. Not all care providers may have the expertise in this area, and so if we had a sort of tailored pathway for this group, then it would cue people and I think make a really important impact to improving their care. So I totally agree with that point.
Yeah, no, that's great. I'm not seeing anybody else with any questions. If anybody has a question, please go ahead and let us know.
Lorena, looks like there is one question, or not question, yeah, that came in from Tom Weiss, but it looks like it came directly to me, so I'm just gonna read it out from my
Great.
computer. So how much of a barrier is the currently predominant payment method for physicians to setting up of a more HK Hong Kong-like system? What are some of the other barriers to change unique to Ontario, Canada?
It's a great question.
Yeah. So, I think that's, it's so complex, the way that, the systems are different. Certainly financial incentives, there are sort of incentives for managing people with diabetes, but that's sort of, measured in terms of the number of visits that people will get, which is not really necessarily an indicator of how complex that patient is. And they won't get specifically paid for referring somebody for team-based care. So if your patient isn't meeting the targets and needing more follow-up, that ends up generating more payments. But is that incentive there to provide? I mean, there are incentives for hiring a nurse and providing that care in an office setting. And so that is built into place. But I think this is it's so complex. But I will say that we're lucky to have a very strong diabetes education program in Ontario. It's well established. We have certification. That framework and the structure is all there. And so if we take that as a starting point, how we can enhance access to that really robust system, and sort of structure it in a way that improves outcomes, and that's able to better track data. I think that there's a lot that we can do.
Thank you, Calvin. I just got a question also that just got sent to me around from Beju Shah. So he was just asking if you had any thoughts on differences in risk perception between young adults in Ontario versus Hong Kong. You talked a little bit about different cultures and values, but what about risk perception?
Yeah, so I don't know of any systematic comparisons that have been done. I think this is the first work that has been looking at young adults. But I do see a lot of patients that are from different backgrounds and different cultures, and I think that I do get asked about these sorts of things. Patients are interested, and I do think that in East Asian populations that there's this sort of like long-term view of health, and like there's like more of an inclination to wanting to know this sort of information. Not that it doesn't exist in other populations, but I think that really is a factor that that enhanced the success of this type of approach in Hong Kong. And so we have to be creative in how we implement that, and leverage this type of the work to be able to benefit all populations, ethnically diverse populations in Ontario.
Great. Thanks, Calvin. We have 1 minute and time for one more question in the chat from Nasiva Rashid. Would you be able to further explain why the probability of survivorship or the projected lifespan could differ between individuals of different ethnic backgrounds after diabetes diagnosis in early adulthood?
Yeah, so yeah, no, thanks for the question. It's a really complex question that probably won't have time to get into, but we've seen in some of our work that we've done using province-wide data that there are very clear differences in the incidence of cardiovascular complications of diabetes, but survival after those complications might differ across people of different ethnic backgrounds. And we don't really know exactly why that is. That might have something to do with differences in how diabetes express phenotypically in those populations. But those are hypotheses that need to be further confirmed.
Yeah, and there's also probably the whole social determinants of health area, that especially in people who are maybe more disadvantaged when they come to, Western environments. So,
For sure.
well, I see we're at 1 p.m. So thank you everybody for your attendance today. And thank you, Calvin, for a wonderful presentation. Please join me in thanking Dr. Key for a very insightful talk. Please ensure you complete today's evaluation for the session. Lydia's added the link to the chat pod. Will also be sent to to your email directly. And I'm thrilled to let you know that our next event will actually be something a little bit different. We are actually hosting our first Discovery Day on June 17th, 2024 at the University of Toronto Mississauga campus from 10 to 4 p.m. We'll be featuring a keynote presentation by Dr. David Campbell, and as well as screening of his documentary film called Low. We're also going to be hearing from our scientists and students at the who've been doing work through the network. So Lydia's added the registration link in the chat, so please feel free to register if you can make it, and we hope to see you all there. We are going to be taking a break from these seminars over the summer, and our next seminar will be September 16th, so please stay tuned for more details. Thank you everyone for attending, and have a wonderful day. Bye-bye.